Hey everybody, and welcome to this special talk this morning. Today we have the great privilege of Dr. Chad Yaghchi, who's from the Imperial College in London. That's going to do a talk for us about how to evaluate dysphagia. So thank you very much, Dr. Chad, for joining us this morning. It's a great privilege, and I'll let you start. Thank you.
Thank you very much for having me, and thank you very much for the kind introduction. So I was asked to talk about dysphagia, and I thought it's too big subject to cover in one lecture. So I thought if we focus on dysphagia evaluation today, and maybe later in the lecture series, I can swap one of my calls with one of my other talks with dysphagia management, or we can keep things. So we'll see. Happy to follow what's required. So when we talk about dysphagia, so we're going to try to cover very shortly, briefly, swallowing physiology, and then we will talk about how to evaluate dysphagic patient from bedside evaluation, PROMs, patient-reported outcome measures, then instrumental swallowing evaluation with the various different methods that we have available. So swallowing process, it's a transport of bolus of food or liquid from the mouth to the stomach. And it's a series of action that happens. So there is muscle contraction. Some of them are voluntary. We start by taking a piece of food, putting it in our mouth, lips, mastication, that's all voluntary. And then there are some non-voluntary muscle contraction. So once the bolus reaches the back of the tongue base, then it is an automated process, which involve sensory component, autonomic, and neuromuscular activity. Essential part of this process is airway protection to close the larynx, and that's the fundamental function of the larynx is airway protection. Evolutionary, that's the first function of the larynx. And generally, it is divided into oral, pharyngeal, and esophageal phases. So with the oral phase, it starts by preparation of the food bolus. So you moistening with the saliva, mastication, and bolus formation using the tongue musculature and the buccal muscles to form that one bolus. Then we have the propulsion. So the muscles of the tongue press against the hard palate, and with a graduated movement, it pushes the bolus backward. And if you look into the video, you will see that clearly in a video fluoroscopy. So you will see here the patient is taking a liquid bolus, and then if you focus on how the tongue was moving, you will see it starts from the front by the tongue pressing against the palate, and then it tips it backward. And it's that phase, the oral phase, ends when the soft palate elevate to close the nasopharynx. Then we move to the pharyngeal phase, and that again, it starts at that point with nasopharyngeal closure. Then the most important part of this phase is airway protection. And there are various different mechanisms involved. So the first that happened, there was that breathing stops on a partial expiration. So that increases the subglottic pressure, and that will be one of the mechanisms of protecting the airway. So the airway there is no air movement into the airway. Then you will have the hyoid elevation and anterior movement, epiglottic deflection, and a glottic closure. And if you look into the video, try to focus on one component at a time. So start by looking at the hyoid bone, which you will see, I hope you can see my cursor where it's pointing. So as the swallow happens, you will see the hyoid bone moves forward and upwards. Then now focus on the epiglottis. So you can see when I play it again, you will see that the epiglottic deflect, closes the airway, and then it springs back into place, and you can see that movement happening. The glottic closure you can't see really on video fluoroscopy, but you can see to a degree on phase. You miss it also on most swallows. So that's the airway protection. Then you will have the bolus propulsion down, and then you will have a pharyngeal stripping waves. We call them peristalsis in the esophagus. In the pharynx, they're mostly referred to as a stripping wave. And you will see that graduated squeeze of start from the pharyngeal constrictor, upper, etc., all the way down. And again, you can look at that when I play the video one more time. And you can see how it squeezes down. This patient have a little bit of residue in the vallecula, but that's possibly within normal limit. The reason I had to play that multiple times that this process is very, very quick. So it is 1 second all of the pharyngeal phase. So you blink and you miss it. So when you're doing instrumental evaluation, you often need to slow down or look multiple times to see it, to see all the various components. Following that, the bolus moves the upper esophageal sphincter open, and that will be the end of the pharyngeal phase and the start of the esophageal phase, and the bolus moves. And this is an autonomous peristaltic movement that happens by contraction of the circular muscles and relaxation of the longitudinal muscles, and starts from the top of the esophagus and moves all the way down. And it moves on a much slower pace within the esophagus. So this is 3 to 4 centimeters per second. So the whole esophageal phase can take seven seconds, sometimes a bit longer, up to 10 seconds in occasions. And there are various different type of peristalsis. So there is the primary peristalsis, and this is what I was describing. It starts by opening of the upper esophageal sphincter as the bolus moves down, and then that peristalsis moves down all the way in a graduated way all the way to the esophagus. The secondary peristalsis is pretty much the same, however, that without a swallow. So there is no opening of the upper esophageal sphincter, no bolus moving from the mouth, from the pharynx down into the esophagus. But we often see this secondary peristalsis when you have residue in the esophagus. Some people do double swallow, etc., gas into the esophagus. So when people have belching or gas refluxing from the stomach to the esophagus, you have a distension of the esophagus because of the gas pressure, and then a secondary peristalsis happens to clear that back into the stomach. Tertiary peristalsis, we see these in elderly, and these are ineffective, random contraction of the esophagus, and they don't contribute to bolus movement. So if we start by looking at bedside swallowing evaluation, so what can you do when you are with a patient in a clinic or in the ward, and you want to assess the patient in a methodical way? So you will start with a clinical swallowing examination. So you need to observe the patient while they're swallowing. So you need to give them something to swallow. You need to look. You need to see how easy is the movement, how quick, is there laryngeal elevation, is there a good lip seal, is there any leak, does the patient struggle with their mastication, oral phase, or are they struggling later? Is there any changes to vital signs? Do they cough, etc.? You can palpate. So if you put your fingers on the anterior neck at the hyoid bone and the thyroid cartilage, you can detect that upward and forward movement. And you can do auscultation. You can listen to the swallow. And there is an increased interest in recent years with auscultation. There is a lot of research going on with using artificial intelligence to try to quantify and try to establish the sounds that you're hearing and try to correlate that as a low cost intervention with evaluating the swallowing. Then you need to try. You can stop at this, and then you can get a very good idea how the patient swallow. But if you want to do that in a more methodical way, if you want to compare before and after, if you want to compare different patients, and if you want to publish research, etc., you need a methodical system. And we use various different things. So we look at the 100 mils water swallow test, and I will talk about that later. The HC functional scale, the voice scale, and then you need to document the patient tube feeding and their nutritional status, which is very, very important as well. So if we start with a functional oral intake scale, so this is a way of categorizing the patient swallowing ability. So let me talk first about the IDSI. So that's the International Dysphagia Diet Standardization. So I'm sure a lot of you are familiar with all terminology. This is not new, but this is become more the standard way of referring to things. So we all use these thick, mildly thick, extremely thick. Then you look at puree, moist and minced and moist, etc. when you're describing a patient diet. So now that has all been combined into a single scale, which goes from 0 to 7, where 0 is thin fluid and 7 would be a regular diet and everything in between. So it's nice to categorize that. So again, especially if you want to compare, when we're trying to compare a study, it really helps if everybody speak the same language, so you can get like a meaningful comparison. Similarly, the FOI scale looks into oral intake categorization, and it goes from either tube dependent when the patient have a gastrostomy tube or a nasogastric tube, and you will have a grade 1 when there is no oral intake at all, and then you go to grade 2, there is some minimal oral intake, grade 3, and then from 4 onwards, you will have no tube feeding, and the patient is totally reliant on oral intake. However, that could be single consistency. They only manage thickened fluid, so we're giving them dietary supplement, ensures, and so on. Or they can manage multiple consistency, diet modification, or completely normal diet with no restriction. 100 ml swallow test. If you look into the literature, there is numerous tests that try to evaluate the dysphagia on the bedside and then try to do this in a systemic way. In our institute, we prefer the 100 ml swallow test. You will see like 20 ml swallow test and various other tests available. So the 100 ml swallow test, you give the patient 100 ml of water and you ask them to drink it as quickly and as comfortably as possible. You time, so you press the timer when they start and you count the number of swallows they needed to swallow the whole quantity of water. And there is a fail pass with the water swallow test. So with a fail, if they start coughing and choking during or post swallow, if they have a wet voice quality, or if they are unable to finish all the waters that they were given. Then you will have, but then you can quantify it. So you will have various measures, and there are normative data for this, depending on the age and gender of the patient. So you will have the swallow volume, which is how mils can they swallow per single swallow, and swallow capacity is how many mils can they swallow per second. And that's again very useful tool for screening, but also for comparison. So you can see, and it's a cheap test you can do. It doesn't need anything apart from glass and some water. Patient reported outcome measures. We really like these. So this is the way of the patient to tell us how their swallowing issue affect their quality of life. And again, you will hear me saying that so many times during this talk. There are numerous that been published and there are numerous that been used worldwide. In our institute, we like either the MDADI, and that will be mainly for head and neck cancer, or EAT10. So the EAT10 is a very useful tool, is a good screening tool. It has a lot of shortfalls in terms of if you really want to look into dysphagia in a research capacity, etc. But it's a most common, most widely used, most published scale for a general dysphagic patient. And again, as I said, it's very helpful if we all speak the same language. So my advice to everyone is stick with the EAT10, but add to it if you need to. So when we work with research, we use the dysphagia handicap index because that will have various different domains, including social factors, how the dysphagia is impacting patients' social and quality of life. So if you want to expand, do the EAT10 because it's a quick and easy, but then you can expand on that. Moving on, we'll start with instrumental evaluation. So you will have various different tests you can do. So the barium swallow, which I'm not going to talk about barium swallow today, is a bit out of scope for this, although it's an essential and possibly the most common tool. But barium swallow mostly looking at the esophagus, and it looks at the upper esophageal sphincter to give you an idea. But it really completely misses the oropharyngeal phase. If you're doing, the rate of frames that is taken with a barium swallow, you might detect something, and it depends on how good your radiologist. They will be watching. Is the radiologist sitting in the room watching as it happens? However, with the video fluoroscopy, then you will have a much richer data for the oropharyngeal phase. You can go the minimum accepted, if you look into current standard, is 15 frames per second. We do 30 frames per second. So you have like a video loop basically when you can slow it down and you can take it frame by frame. And within that 1 second of pharyngeal phase, you can have 30 frames and you can look at it really in a great detail. And then we do various different consistency to evaluate the swallow. So we start with the thin fluid, and then we move upward. We try puree, and then we can try some solid, and you can add barium to these. It mostly, with the video fluoroscopy, as I said, barium swallow mostly evaluate the esophagus with a little view of the oropharyngeal phase. Video fluoroscopy is the opposite. You're mainly looking at the oropharyngeal phase and the upper esophageal sphincter, and we do an esophageal follow-through, which is more like a screening. If you really want to look at the esophagus, this is not sufficient, and you need to do like a formal barium swallow with oblique views that you can get like really good view of the esophagus and look into if you're looking achalasia, dysmotility, etc. But this is will be a good screening tool, and if there is abnormality, then you can discuss with the radiologist to do a formal barium swallow. And there are examples just to show you what you can see on video fluoroscopy. You can see here there is slight prominence of the cracked pharyngeal bar and early pouch formation in the first patient. Second patient, when you will have like mass aspiration, you can see this patient, the contrast is running down on the anterior tracheal wall. And a quick video to show you. You will see this patient, they swallow, they have a cracked pharyngeal bar, incomplete opening of the upper esophageal sphincter, and significant residue, and they need multiple swallow, and despite that, they have significant weakness of the pharynx, so the stripping wave is compromised, the upper esophageal sphincter is not opening, and as a result, there is a lot of residue hanging around in the pharynx. So same thing, there is plenty of ways to try to quantify a video fluoroscopy, and then you need to try a single method and to try to stick with it. So the way I like to look at it and the way we use in our institute, we use two things. I think the past penetration aspiration scale, this is the most common, most consistent across everything. So it goes from 1 to 8. It is most widely used. It's been adapted for fees as well, and it goes from 1 when there is the material, the none of the contrast enters the airway, all the way to 8 when there is frank aspiration with no effort made to eject it. However, my favorite way to evaluate a video fluoroscopy is the digest scale, which is a way of making that meaningful in terms of its clinical relevance. So it's good to look and say how many millimeters moving here, how many millimeters moving there, but that's very useful in research. If you want to make it into day-to-day healthcare, it works better if you try to make it relevant to health needs of the patient and the health effect of the swallowing. So the digest scale will try to look into the safety and the efficiency of the swallow. And the safety means if it's impaired, the patient is aspirating, and that can lead to chest infection, pneumonia, etc. And it looks at the efficiency, and the impairment of that means there is pharyngeal residue. And if that's severe, then the patient may not be able to meet their nutritional demands. They have a very restricted diet because they manage only specific consistencies. I'm not going into too much detail. So the way it works with the safety grade, it takes the PAS score, so it's based on the PAS score, but then it makes it a bit more clinically relevant. So when you look into past 5 and 6, it is different if that single event with a trace, or is it something that intermittent or chronic. And again, what a past 7 and 8, when it becomes like really compromised swallow, it further divided down. Similarly, the same thing looks with efficiency. So you will have residue, minimal residue, less than half, etc. And then that breaks it down. And it gives each one from the safety, you get a grade from grade 0 to grade 4, and efficiency you get from grade 0 to grade 4, and you can plot it into that, and you can get your overall grade. So it gives you 3 scores. It gives you overall grade, it gives you safety grade, and efficiency grade. And then it's a very nice way to quantify it without getting bogged down about how many millimeter there and how many millimeter here. So moving on, the second tool that we use when we're doing our instrumental evaluation is the flexible endoscopic evaluation of swallowing, or FEES. So this is, you try to see the patient while they're swallowing using an endoscope. So we put a scope down the patient nose, and we start giving them various food and liquid consistencies, and we observe them swallow. And it needs two assessors. You need somebody to be scoping and somebody to be assessing on the screen, looking at the screen, giving the feedback to the patient. And then you need to record that because you often will need to go back and look at it when you're trying to make some quantification. It's good to get whole view, and you can give a patient a lot of the information immediately, but you need to go back, look at the video, and then do your scoring if you're going to try to quantify their swallowing function. So why fees? So if you have video fluoroscopy, and a video fluoroscopy is, I still consider video fluoroscopy is the gold standard for swallowing evaluation, but it does not give you all the information. And fees and video fluoroscopy are there are you get some data commonly between the two, but they often in complex patients we do both because each one will give you different sets of data, different views on the swallowing function. So with fees, it allows you to evaluate the secretion, patient secretion loads at baseline. It allows you to evaluate the anatomy and the integrity of the laryngopharyngeal system. You can look into vocal cord function. It allows you to, it's something that you can repeat. It's very useful when you have a patient that you can't take them to the video fluoroscopy suite, or if you don't have a video fluoroscopy suite. So patient in ITU, you're not going to be able to do video fluoroscopy, but you can do fees on a patient in intensive care. The patient who have contraindication for contrast, then you will have the practicalities of it. It's practical because it's portable. You can do it on a bedside. Now with the improvement in technology, you can even do it in a patient home. So we have like in some of our speech and language therapy based in the community, they will have a small screen, disposable scopes, or even scopes that they can clean. They can go to a patient home or nursing home, and they can do instrumental evaluation. It's also real food and medication. So it's not barium, it's not contrast, it's not modified consistencies. This is you give their patient what they eat. And we often tell the patient if they have something they're struggling with, to bring it with them. If there is a specific food that they struggle with, if there is tablet, they can bring it to the test and then we can test it and we can look at the screen with the patient. Another very useful thing is you can give the patient immediate biofeedback, and that's often very helpful. So I run a clinic once a month on food aversion, and most of the time we just sit the patient on the screen, you get them to watch, and we start challenging them with increased various different consistency. And you give that patient that immediate feedback. You can show them that it is safe. You can show them that they're not aspirating, and you can have that meaningful discussion with the patient while the swallowing is happening. You can teach the patient various different compensatory strategies. So you can test if head turn can make a difference, if a chin tuck can make a difference. And if you're going to have some rehabilitation strategies, it is good to show the effect of these to the patient and teach them how to do it properly. Just to play you an example of one of our airway patients who had some complication post-surgery. He was in intensive care at that point. You have an NG tube. He'd just been extubated, and you can look into their swallowing function. So you will see we're giving them first, which is thin fluid. You will see that coming in a second. They're struggling here with their oral phase a little bit, and because of ITU and all of that, but you can see significant aspiration. You can see they have unilateral vocal cord movement. This patient have post-radiotherapy posterior glottic stenosis that was dilated. You can see the residue. You can see contrast material going in, penetration through the posterior larynx interarytenoid area. And that's just like a bad example. Not every patient is this poor in their swallowing function. So to do the fees methodically, you need to look into 5 factors. So you need to comment on the anatomy involved in the pharyngeal stage of the swallowing, the anatomy of the pharynx, the piriform fossa, are they dilated, vallicular, epiglottis, movement of the vocal cord, and palate elevation when you're starting from the top. So when you put your scope, you first thing you evaluate is palate elevation, and then all the various movements in the larynx and pharynx. So we talked about the movement, the sensation, Can they feel the scope? Is there any response when they swallow? And then you comment on their secretion load, and you can quantify these. There are scores for secretions, and then you look into the swallowing function with foods and liquids. Then you can try some therapeutic maneuvers, and these will be the 5 stages to do this methodically. And similarly, there are various different scores. I love the digest, as you might have gained by now. So it's been adapted for fees. So the same principle that applies to video fluoroscopy has now been adapted to fees, and it's exactly the same thing. So you can look into pass scores, because you can do pass scores for fees, and then you can grade them from grade 0 to 4. I'm not going to repeat all of that. It's exactly the same system that you use for video fluoroscopy. And while you can't compare video fluoroscopy to fees, but it's helpful to have the same principle, because more or less it looks at the same thing. So the residue is this in principle is the same, and the pass in principle is the same, although the evaluation may not give you the exact same scores for the same patient if you're doing fees versus video fluoroscopy. However, fees has its own limitation, of course. So it's only looking at the pharyngeal phase of swallow. So it completely misses the oral phase, and it misses the esophageal phase. And it lacks that view that you get with video fluoroscopy of that continuum of swallowing, because swallowing is a single process. Although we try to divide it, it is what happens somewhere in the oral phase affect what happened in the pharyngeal phase, and affect what happens in the esophageal phase. And with fees, you lose that continuum view of the swallowing function. You can't see the upper esophageal sphincter opening. You can't assess hyoid-laryngeal movement. And you lose sight of the bolus at the height of swallow. So you have the whiteout for 1 second, which is the critical second, this is the bit that you want to see most. This is the bit that you miss in somebody with a normal swallow. You will see it in somebody with a compromised swallow, but in somebody with a normal swallow, that 1 second, your scope will be white out, and you only get the view back when there is the epiglottis is reflecting back to its resting position. You might miss if there is fistula. You might miss it if there is fistula posterior tracheal wall, and you will need video fluoroscopy for that. And you will miss reflux and regurgitation within the esophagus. Nevertheless, the two are complementary, and this is a general pros and cons for each one. So I'm not going to go through that, but you can look at that. There is plenty of these you will see in the literature, and if you do a quick Google search, you can see all of these and where the tool is useful more than the other, and they are often complementary. And finally, in the last few minutes, I will talk about high resolution manometry. So the manometry, so this is the old style manometry, and it's a pressured sensor. So you put a catheter, goes from the nose all the way to the stomach. And in the traditional manometry, you will have a sensor 1 every 3 centimeter. And as swallow starts, you can see the top one will be in the pharynx. You see the peak of pressure, and then as the bolus moves forward, the pressure wave moves all the way forward. Then there is a drop of pressure for the lower esophageal sphincter, and the bolus moves into the stomach. So if you take that same thing, but you make it a lot more richer data set. So if you have up to 36 sensors rather than every 3 centimeters. So now you have a sensor every centimeter. And often in some of these catheter, you will have multiple sensors at each level. So it gives you 3D topographic view. And you represent the swallow, the pressure change with a heat map rather than with the lines, you get with a high resolution manometry. So in here, you will see distance from the nose all the way down to the stomach, and that's the time, the time. And you will see two pressure bands at rest. So you will have the upper esophageal sphincter and the lower esophageal sphincter. And as swallow comes in, you can see that pressure drops in the upper esophageal sphincter, while the pressure raises in the various parts of the pharynx. Then you will have the peristalsis moving all the way down, and you have the S1, S2, and S3, which is various segments of the esophagus. You will have the transitional zone between the stratified and smooth musculature, and you will have the opening of the lower esophageal sphincter. And that's now the gold standard for evaluating esophageal dysfunction. So For that, you will have a very standardized way. So there is the Chicago classification, which is now its own fourth version, and it looks mainly it starts to simplify it. So this is mostly the area of gastroenterologists, but it's important to understand if you're managing patient with dysphagia, because you can't simply just ignore the esophagus because we are ENT. So you start by looking at the lower esophageal sphincter. If there is failure of relaxation, then you're looking into achalasia, different types from type 1, 2, and 3. If that's opening normally, then you have various different, either it is hypomobile, so you can see complete absence of contractility, or ineffective swallowing, so that's hypomobility of the pharynx. So this will be you can see like peristaltic breaks, etc. So there are various different categorization for esophageal dysmotility. And if, in the contrast, you have a normal opening but raised pressure rather than low pressure, then you're looking into distal esophageal spasm, jackhammer esophagus, etc. This is more our area, and this is developing field rather than a standard practice. We don't have the equivalent of a Chicago classification, although that's possibly coming soon. And this is the pharyngeal high resolution manometry. So here the catheter is sitting slightly higher up into the pharynx. And this is something I'm really interested in. I have one in my office, and I do this personally myself. And it gives me additional data that I can add when I'm evaluating and managing a patient with dysphagia. So you're looking here, you're looking at the anatomy. You will see the first pressure band will be at the nasopharynx. So that's the palate pushing against the catheter. This is the oropharynx, tongue base. And here you can see, this is not every patient is like this, but you can almost see every separate pharyngeal constrictor. And then you will have the upper esophageal sphincter. You can move it, you can see it moving upward as the hyolaryngeal elevation. And then you will have post-swallow hypercontractility, and that will be the start of the peristalsis going down into the esophagus. And as I said, although we don't have anything that is as established as the Chicago classification, we have the International Manometry Working Group, which published their first guidelines back in 2018, and the new set of guidelines will come very, very shortly. That was the group met recently, a few months ago, and there will be an updated guideline coming soon. So just very quickly to look into what can you see in pharyngeal high resolution manometry. I look at the pharyngeal contractile integral, so that will give you the vigor of the pharyngeal contraction, and if that's weak, then you will have a global weakness of the pharynx, or if it's one part of it, then you will have localized weakness. I look at hypopharyngeal intrabolus pressure, so that's the pressure 1 centimeter above the apogee of the upper esophageal sphincter, and that will tell you if there is pressurization in the pharynx, if there is increased pressure in the pharynx, which means that the upper esophageal sphincter is not distending well. Then you will have the integrated relaxation pressure, and that's the pressure across the upper esophageal sphincter. And if that's raised, then there is incomplete relaxation. And then you can look at the maximum admittance, which tell you about the ease of bolus flow across the pharynx, across the upper esophageal sphincter. And this is how I think about it. So if that's low, the contractile integral means there is weakness. If there is incomplete relaxation, so you will have like a crack pharyngeal spasm, you will have increased pressure. But often you don't see that, although there is hypertrophy and there is reduced bolus transfer, that it is relaxing. So the pressure is dropping. However, there is restriction to bolus movement, and you can measure these with intrabolus pressure or maximum admittance. So just a final slide. This is our protocol. You don't need to do that for every single patient, but if you're assessing a dysphagic patient, you possibly will need more or less all of these or a group of it. So we do bedside swallowing examination, 100 mL water swallow test. We ask the patient to complete the EAT-10. we document their voice and ETSI scores, then we choose, is that sufficient or do we need to do an instrumental evaluation? And we choose either FEES or video fluoroscopy, and often both. So FEES is very useful for us as an airway surgeon for pre and post surgery. It gives me a lot of information to see the patient swallow beforehand. It's helpful for their aspiration and the pharyngeal dysphagia, and it's very helpful for follow-up. So sometimes we do video fluoroscopy pre-treatment, and then you don't want to irradiate the patient repeatedly, so we can follow them up with FEES, and then if need to, we can go back to video fluoroscopy if required. Video fluoroscopy, as I said, in my eyes, remains the gold standard tool that we have. It helps us when there is issue with aspiration. If we're suspecting aspiration, it's a lot more useful than FEES in terms of quantifying it and seeing it more clearly. If there is regurgitation, if you're suspecting upper esophageal sphincter issues, and it's helpful to look into the oral phase of swallow. And I add high resolution manometry depending on the patient. As I said, this is not standard, but this is in my hand. I found it useful, especially when I'm looking at upper esophageal sphincter pathology and to see the effect of my dilation, the effect of my myotomy or Botox injection. And on that, I will stop and I will be happy to take any questions.
Thank you, Dr. Chad, for an excellent talk. It was a great overall view of the evaluation of dysphagia, so we really appreciate it. Thank you. Are there any questions?
Can I ask a question? Yes, so it's Johan Pagan. Thank you very much. There's real science and arts, I think, combined there. So I've got two questions. The first is, if you have a patient with suspected cricopharyngeal spasm, what would the workup be for that, the minimum workup? And the second one is what is the current understanding about the pathophysiology of Zenker's diverticulum? Is it in coordination of swallowing that the cricopharyngeus isn't relaxing, or any ideas on that?
So for the cricopharyngeal spasm, I feel we overuse the term of spasm. If you look at it on a video fluoroscopy or on a barium swallow, so you will need to do your bedside swallowing evaluation, get the history and all of that. But I think the test that tests for it, and the standard test currently, is either a barium swallow or a video fluoroscopy. And you look and you see that cricopharyngeus bar, you see the failure of opening. However, I think the spasm is overestimated in these. These studies will overestimate spasm because in the majority of the time, when you do manometry, there is no failure of relaxation. There might be a hypertrophy, there might be a web, submucosal web that you can't see, and you will see the effect of that on manometry with reduced admittance, so reduced bolus movement across the upper esophageal sphincter, but it's not true spasm. So in my hand, and because I have it available to me, I do high resolution manometry on these patients before I treat them. And that will help me distinguish. If there is a true spasm, I try them with Botox. I'm not a fan of Botox into the cricopharyngeus. I do it a lot with RCPD patient, but for dysphagic patient, it's often lead to more problem. You need to have it like really concentrated, really accurate injection, because otherwise it spreads into the pharyngeal constrictor, and then you will have patients struggling more with their swallow. So what do you need to work the patient up? So the bedside swallowing evaluation, and you will need either a barium swallow or a video fluoroscopy to look at the upper esophageal sphincter, and then you can make your decision based on that. I tend to start with a balloon dilation, and I reserve the Botox if I have a confirmed failure of relaxation on high resolution manometry. In terms of Zenker, I think, to my mind, it is failure of relaxation in the muscle. So this is cricopharyngeal spasm, failure of relaxation, and the pressure from the pharynx coming up lead to the herniation. But you will have inherent weakness of the posterior pharyngeal wall. So you will need that combination of the two.
Yes, because I did 4 Zenkers yesterday endoscopically, and the CO2 laser, and I always just get the sense that it's the muscle that's the problem, not the weakness so much. Is that?
Yeah, exactly. That's exactly my view. You will have patient with zincers, you have like a really difficult view and you can't do your stapling. You can put some Botox in there if you can have some view, or if you have no view at all, you put a balloon and you dilate it. And they report improvement of symptoms despite you not opening the pouch. So it is the muscle spasm is the the baseline of it.
Okay, thank you very much. Just while I've got you, so any thoughts on doing a cricopharyngeal myotomy endoscopically as opposed to Botox?
Yes, and I think it's a lot better results you get with that rather than doing Botox. If you have hypertrophy and you balloon dilated, they got a bit of improvement. These patients do very well, especially when you have this fibrotic muscle, so you can do the myotomy. Botox you can test with the Botox. If you have a true spasm and failure of relaxation, you can test them with Botox, and if they do well, you can move to myotomy. So yes, I am a fan of endoscopic myotomy. I do it with a CO2 laser, and often try to put like a one stitch to close it if I can.
Thank you. Yes. Any other questions from here? And that other area, which you probably see a lot of, is post chemoradiation dysphagia. How would your workup perhaps differ from the other patients?
It's well, the workup. The workup is pretty much the same. In these patients, you often need both video fluoroscopy and FEES, because it gives you different information. FEES is essential in this patient cohort because they aspirate, then you will see the effect of radiotherapy. You need to evaluate the movement of the vocal cord. So FEES is essential, and you often will need both FEES and video fluoroscopy with these patients. You will have various different things you see with a post chemoradiotherapy. You will have the weakness of the pharyngeal muscle. So sometimes it's so weak, it's like a baggy balloon. There is no contraction left into the area at all. And then you will have the issues with airway protection, mobility of the vocal cord, the issue with the sensation, which you can see better on a FEES. But then you will have upper esophageal sphincter pathology. And here you often will see, sometimes you see bar, but there is, if you do manometry on these patients, the sphincter is dead. So it's been completely replaced with a fibrous tissue. And these patients, Botox does not work on these patients at all. To the contrary, if you Botox these patients, you make the situation a lot worse. So here, your options are limited. Your mainstay of treatment is rehabilitation with a speech and language therapy. And you will hear from Professor Justin Rowe later in the year within this lecture series. But for the upper esophageal sphincter, we do balloon dilation with a view. A lot of the time it just like give you that extra, try to open it, maybe it will help with the bolus flow. Not always most satisfying results, but it is your options are often limited in this patient cohort.
Thank you very much. Are there any other questions? Any on the chat?
I don't see any other questions on the chat. Anybody from the panel? No, I don't think so.
Okay.
Yeah. Thank you very much, Dr. Chad. That was an excellent presentation. We really appreciate your time and getting up early to give us this lecture. And we look forward to your lectures further on in the year. So thank you very much.
Well, thank you ever so much. It was one wonderful lecture.
It's my absolute pleasure. Thank you very much.
Thank you. Thank you so much.
Okay. Have a lovely day.
Bye-bye.
Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you very much, everyone, for joining us. I will end our meeting for today and have a good weekend ahead.